Hello, I am Kim Young-soo, and I am here to talk again about the topic of a 10-year clinical evaluation. Last time, I shared my experiences and how the CMI concept has been applied in clinical implant practice. This time, I would like to talk about how I have utilized Neobiotech implants in various clinical situations. In particular, I will be discussing cases of application in the maxillary anterior region. The maxillary anterior region is a critical area where aesthetics are important during implant placement, making it quite challenging. Therefore, it requires a lot of attention. When considering CMI fixation in the maxillary anterior region, there are often cases where there is apical concavity at the root tip. In this case, if the alveolar bone is in a healed state, you can achieve CM fixation by securing the C and M areas and performing bone grafting in the apical region. I will talk about immediate placement after extraction. If you secure fixation in the M and I areas, or if there is apical concavity, you may need bone grafting in this area, such as if the extraction site is large, there may be cases where fixation is obtained only from the apical side. You might have a lot of concerns when deciding the timing for implant placement in the maxillary anterior region. If immediate placement or early placement after extraction is possible, I believe it would be advantageous to proceed with it. Of course, placing the implant after preserving the extraction site through ARP, alveolar ridge preservation, is also a good method. However, considering the convenience of the patient, I think that early placement may be more advantageous whenever possible. This is a patient who came in due to a fracture of the central incisor. The patient was over 65 years old and eligible for insurance coverage for implants, and I also explained the post-core crown option. However, since the patient wanted the implant, I placed the implant after the extraction. This photo is a panoramic X-ray taken before the extraction and a clinical photo of the mandibular occlusal surface. The results of the CBCT taken before the extraction showed that the buccal bone was thin but remained healthy. Based on this, I determined that immediate placement was possible and established a treatment plan. I will talk about the treatment stages. First, to ensure a safe extraction, I cut the lingual side and separated the tooth in the mesiodistal direction. After that, I carefully proceeded with the extraction and took a periapical X-ray to check the implant path. At this time, since the extraction site was deep, I used a 2.2 mm drill instead of a regular guide pin to check the parallelism with the adjacent teeth. After that, I placed the implant. I made an effort to secure a gap of at least 2 mm on the buccal side. After placing the implant, I checked the adjacent teeth and surrounding conditions to ensure the depth, and I made sure to verify the placement depth through a periapical X-ray. If it was determined that the appropriate depth was secured, I performed bone grafting using allograft between the buccal bone and the implant. The extraction site was carefully covered with a wider healing abutment during the surgical procedure, and the remaining gap was precisely filled using collotape to ensure optimal healing. After that, I completed the suturing with a simple figure of 8 suture. Finally, after the implant placement, the results from the panoramic X-ray and CT scan confirmed that the implant was placed stably without significant perforation in the apical area. This is appearance after the healing process over 3 months. After attaching the abutment and taking the impression, I completed the restoration with a PFM crown. It has a color similar to the adjacent teeth, and the gum healing went well, so the patient was very satisfied. In the appearance after 1.5 years, you can see the papilla area slightly filling in. The gums are well maintained without any signs of inflammation or bone loss. However, the bone area gives a slightly sunken impression compared to the adjacent teeth due to remodeling, but clinically, there is no major issue. The next case I will show is one where immediate placement was unfavorable, so it is an example of early implant placement, meaning the implant was placed after soft tissue healing. This was a tooth that previously used a post-core crown, but the crown fractured in secondary caries were severe, necessitating extraction. Due to the size of the lesion at the apical area, we determined that immediate placement was unfavorable. The CT images clearly showed that the buccal bone was completely and entirely lost, making immediate placement difficult. Therefore, we plan to first perform the extraction and then place the implant 4 to 6 weeks after the gums have healed. After carefully performing the extraction, we place the implant 6 weeks later following the healing process. 6 weeks later, the CT images also confirmed that the buccal bone was completely lost. During the surgery, after elevating the flap, the loss of buccal bone was clearly observed visually. When proceeding with the drilling, I was careful to ensure that the palatal bone was hard and that the drilling direction did not deviate. During the implant placement, I rechecked the relationship with the adjacent teeth using the drill that was used. After placing the implant, initial stability was achieved, but due to significant dehiscence, bone grafting was necessary. Therefore, instead of attaching the healing abutment, I secured the cover screw and proceeded with the bone grafting. During the bone grafting process, I carefully harvested surrounding autogenous bone and meticulously grafted it into the exposed thread area of the implant. At first, I grafted it. Then, using a slow-absorbing xenograft, I carefully and precisely performed additional contour grafting and covered it with a collagen membrane for suturing. I used horizontal mattress sutures and interrupted sutures for the stitching. Post-surgery, the panoramic X-ray shows that the implant is properly placed. Additionally, the CT images confirmed that the buccal alveolar bone graft has been well reconstructed. After 4 months of healing, I performed the second surgery. After the incision, I very carefully and precisely attached the healing abutment securely in place. After the second surgery, the CT images showed that the bone graft in the alveolar bone was well maintained. Comparing the pre- and post-surgery CT images, you can see that the area where the buccal bone was completely lost has been reconstructed through bone grafting. I created a temporary tooth and, after taking impressions, completed the final prosthesis. After approximately 1 year, we could see that the papilla had risen significantly more than at the time of the final prosthesis. During the visit after 4 years, oral hygiene was not good, but the patient was using it well without any major issues. After 4 years, the periapical X-ray showed that the implant was stable and maintained without any crestal bone loss. The reason the patient came in was due to pain in tooth number 37, and a periapical lesion was identified, so root canal treatment was performed. I explained that the pulp complex lesion was severe and that the prognosis was not good. I informed the patient that due to the wisdom tooth, There were caries in number 47 and number 48, and additional treatment was necessary. Comparing the follow-up CT images, we can see that the grafted buccal bone has matured stably. When compared to the initial photos, it is evident that a lot of healing has taken place. Now, let's take a look at how to utilize the CMI concept in the mandibular posterior region. When using Neobiotech implants, there may be times when the placement feels tight. At this point, it's important to achieve proper initial stability and avoid overcompression. By utilizing the CMI concept, we can manage this effectively. If the insertion torque is less than 30 Newton-centimeters, the submerged technique is appropriate. If it is above 30 centimeters, you can attach healing abutment and proceed with the non-submerged approach. However, you need to be careful not to exceed 40 Newton-centimeters of torque. It is especially important to achieve fixation in the crestal area. Overcompression can lead to bone loss, so caution is necessary. The bone quality in the crestal area is often dense, while the lower bone quality is usually relatively softer, so the implant design and drilling concept must be carefully planned. If using the delayed loading method, you can place the implant after full drilling or widen the crestal area through countersinking before placing the implant. However, if planning for early loading or anytime loading, you should secure stability through tapping after drilling before placing the implant. In this process, you should minimize the gap between the implant and the bone, and after minimizing the compression applied to the crestal area, you should place the implant. Next is the process of placing the implant for tooth number 46. After the incision, carefully and precisely form the flap. Check the bone quality and structure through initial drilling. The surgery was carried out while checking the differences in crestal, middle, and inferior bone density. Use the guide pin to check the implant path. After completing the previous steps, you should then proceed to continue with the drilling process. Finally, tap the hard bone on the crestal side to prevent excessive compression. This step may feel cumbersome, but it is essential for achieving optimal fixation during Neobiotech implant placement by avoiding excessive torque or overcompression, making it very useful for securing stable fixation. This shows the installation of the IS2 fixture. Since the fixation turned out well, this shows the attachment of the healing. After placing implant number 46, the healing abutment was attached and the suturing was completed. You can see the clinical photos and the final prosthesis. Even 3.5 years after the implant placement, the implant is being maintained stably without any bone loss on the crestal side. A 67-year-old had implants placed at number 44 and number 46. For the premolars, implants with a diameter of 4.0 millimeters and a length of 10 millimeters were placed, and for the molars, implants with a diameter of 4.5 millimeters and a length of 8.5 millimeters were placed. After placement, this shows the implant being placed while minimizing the torque on the crestal side using tapping, as seen in the panoramic radiograph. This is a panoramic radiograph after loading the final restoration. This is another case where implants were placed at number 45 and number 46. Approximately 6 weeks after the extraction process, delayed placement was performed, and partial bone healing is observed. After forming the flap, the granulation tissue was removed. The adjacent teeth were also thoroughly subjected to root planing. After that, implants with a diameter of approximately 5.0 and a size of 10 millimeters were placed in both number 45 and 46. A graft using allograft bone was performed in the gap between the implant and the alveolar bone. After using the collagen membrane, suturing was performed. This is the appearance after the healing period. The second surgery was performed after 4 months. This shows the result of bone healing. After the second surgical procedure was completed, a temporary dental prosthetic was employed. This prosthetic was used to carefully adjust the available space in the mouth and to perform the necessary space closure. The temporary tooth acted as a placeholder, ensuring proper alignment and spacing during the healing process, which is essential for the success of the dental treatment. This is the appearance after completing the prosthesis. The gap between the existing teeth 3 and 4 has been eliminated. You can compare the appearance after completion using a panoramic radiograph. In the panorama taken after 5 years, the implant is being used well without significant bone loss. The clinical photos also confirm that the condition is stable without any signs of inflammation. This person is a patient who visited during the early days of my practice, and they are now over 80 years old. At that time, they were in their 70s, and the crown was in a washout state due to severe caries on tooth number 36. Extraction was necessary, and an implant was performed after the extraction. At that time, bad habits were suspected, but there were also points that I overlooked. After forming a full layer valve, the implant was placed, and allograft was used to fill the gap in the root area. Afterward, suturing was performed, but there was a slight dehiscence initially, which healed well. A healing abutment was attached, and a PFM prosthesis with a metal occlusal surface was created for the patient. This is the appearance after completing the prosthesis. During the routine dental checkup after a period of 7 long years, it was discovered that the abutment was unfortunately fractured, and as a result, a completely new prosthesis was meticulously created. These are the clinical photos taken after the fabrication was completed. This is the follow-up photo taken after 9 years. This is a 10-year follow-up photo taken during a recent visit, showing that it has been maintained relatively stably without crestal bone loss. Next is a case of immediate implant placement in the mandible, effectively utilizing CMI implants. Implants were placed at number 34 and number 36, and the plan was established using preoperative CT. Number 35 was extracted in advance due to pain, and immediate placement was performed for number 34 and number 36. These are clinical photos taken implants implant placement. The healing abutment was attached with precision, and suturing was performed. Later, the properly placed implants could be confirmed in the radiographs. After taking the impression, the abutment was connected, and the final prosthesis was completed. After completing the final prosthesis, it was confirmed that there was a stable condition without any signs of inflammation in the panoramic radiograph. You can also observe a well-healed condition in the periapical radiograph. The grafted bone area seems to still be maturing. In the maxilla, RPD is currently being used, but the patient is satisfied with the mandibular implants and wishes for additional surgery. Let's take a look at a case of full mandibular implants. This person has only 2 remaining teeth in the mandible, and the lack of other teeth made it difficult for them to eat. Implants were sequentially placed starting from the mandibular molar area, and after placing them in the anterior and canine regions, the final prosthesis was completed. In the 2-year follow-up photos, it was confirmed that the condition is being maintained stably without crestal bone loss. In the meantime, implants were placed in the maxilla at number 16, number 24, and number 26 to complete the occlusion. In the 3-year follow-up photos, the patient mentioned that eating has become easier and they have gained weight. In the 3-year follow-up photos, there were no major issues with the prosthetics, and in the 5-year clinical photos, the implants were being used stably. In the 5-year radiograph, it can be clearly and distinctly noticed that the condition is being maintained, without any significant bone loss. After extensive research and numerous studies, the conclusion I want to make is that it has been determined that tapered CMI implants can be successfully used in both the maxilla and mandible. Additionally, I have confirmed through experience that the CMI concept is very useful for achieving initial stability. It has also been proven that utilizing the CMI concept allows for anytime loading and maintaining a stable crestal bone level. Moreover, it has been confirmed that CMI implants can be successfully used not only in single implant cases but also in full mouth implant cases. Therefore, based on my experience, I can certainly and confidently say that CMI implants are very suitable for you to use. Thank you.